Thank you, Mr. Chairman, and apologize on the front end that these questions may have been addressed, and as a new member, I'm still trying to understand some of your methodology.
I'm a new director, Senator, so I'll, if I can't help you, then my colleagues behind me will.
Well, I just, having seen in the secondhand some of the scoring that has been done on some of the proposals around healthcare reform, particularly as regards prevention, wellness, system benefit design, that seem to be scored relatively low. Yet seeing, and I wonder whether how much kind of real life examples are brought into that scoring process, because one of the things I think that has been, as I've redelved into this issue, that is a dynamic, real change process, is that corporate America, or at least the more progressive companies, large employers, self-insured, that have their own benefit design plans, there's really been a fairly radical change in the last just 3 to 5 years in companies that have really aggressively gone on cost containment. I mean, many of us here have talked to Steve Bird in terms of Safeway, but there's a host of other companies that have had similar actions, much of that based upon issues regarding around prevention and wellness. Is that kind of real life examples factored into your analysis in terms of scoring costs?
Yes, it is, Senator. We take the real life examples very seriously, but I understand that our analysis of the effects of prevention and wellness initiatives is one thing that has made, I think, more members of Congress more frustrated with us than almost anything else. Let me spend just a few minutes explaining how we think about this and what the evidence shows. Think of a simple medical test to start with, and then I'll broaden the scope. That test will discover that some people have some condition that can then be treated in an early stage rather than waiting until it becomes more apparent later. For that person, doing this test early is good for their health and reduces their health spending, perhaps substantially. Challenge is that there are a lot of other people, given the same test, who will come back negative, thankfully. Giving them the test has raised their health spending relative to what would otherwise have occurred. And not very much, presumably, per person relative to the savings for the people who end up having the disease caught early. On the other hand, for most diseases, there are many more people who don't have it than do have it. So analyzing the effect on overall health spending of an extra test involves weighing the extra cost, the small extra cost for a large number of people who come back negative against the large savings for the small number of people who come back positive. There are actually hundreds of studies that have done this for specific preventive measures. And as you would expect from this logic, preventive measures that are more targeted than others are more likely to be cost-saving. So all sorts of screenings that are cost-saving if done on a periodic basis for older people are moderately costly if done on a periodic basis for younger people, or very costly if done on a very high-frequency basis for younger people.
But can I interrupt? I mean, I think I understand this piece. I don't mean to be rude, but I got one other question I want to ask. My time's running out. But I guess that's based upon procedural screenings. What I think has driven a lot of the actions that have come out of the private sector corporate plans have been incentives towards behavior modification, not in terms of identification of a disease.
So there are a few issues, and Safeway is a good example of this. And we've talked, in fact, with Steve Bird, and we've talked with actuaries and financial people at his company as one example of this. Safeway's done a number of things. One is they renegotiated contracts with their healthcare providers. They bargained harder. The second thing was that they gave the employees financial incentives to economize first on the use of health services, just the sort of cost sharing that I discussed to Senator Gregg a few minutes ago. Third, they provided real financial incentives for better, more healthy behaviors. Those are much more forceful policies and go well beyond wellness itself. And that collection of policies, if presented to us, would save money. But that's much more aggressive on the behavior side than many of the things that we see that are just more generally encouraging of good behavior. And then we need to try to assess how much any individual program is actually going to alter behavior and what effects it will have. And of course, some of these things will have larger effects outside of the 10-year budget window, but we just don't do numbers too far out because it's too uncertain.
Mr. Chairman, could I ask one more question? I know my time's expired. It's an issue that I think that I have before you, and let me preface it again by saying it is a challenging issue that has not only healthcare, political, financial, but also moral implications as well. And that is, I have legislation pending about raising end-of-life issues, recognizing that 70% of Americans have no advance directives, that have no living wills, other type of issues. And all the data, as I've seen, is that if we encourage the utilization of more palliative care, if we train people in the medical field to have these kind of conversations with families earlier on, if we engage religious leaders as well to be willing to talk about these issues, and that they're real living examples that actually enhancing hospice-type services outside of the last 6 months when folks are still in the curative stage, to encourage these conversations that, and by no means, let me make very clear here, no indication here of any effort to limit people's choices, limit people's care, limit all their options, but just make sure families have these options. That companies like United and Aetna and others who have enhanced, increased these services, that more people choose perhaps not to spend their waning days in a hospital, but choose other options. We think that, and they have shown that increased patient satisfaction, increased family satisfaction, and on average, cost savings north of $5,000 per person. We're trying to work with your staff now on trying to get approaches like this scored, and because it seems to me that this is an area that, again, because it goes beyond the realm of politics, it is a deeply moral and religious issue as well. But encouraging these conversations, we found from the faith community a real willingness to engage on this issue. Again, just laying out people's choices and encouraging them to have these conversations. I would hope we could work with your staff on trying to, this is a sensitive area, trying to have this area looked at. And again, recognizing that there are real life examples, models being used that demonstrate, as I mentioned, both increased patient and family satisfaction and cost savings. Have you all looked at this issue at all?
Senator, we have not looked sufficiently at this issue, and we recognize that that is a gap in our healthcare work, and a gap that we are eager to fill when we have a chance to do that, and we are looking forward to working with you and your staff.
I have legislation that it's before you that we've been urging you to get some kind of scoring back, and I know you've got other things on your plate, but I'll take that as a commitment that you'll work with me directly on
yes,
trying to get this.
We certainly will, Senator, and I will check on this when I get back to the office.
Thank you, Dr. Elmendorf. Thank you, Mr. Chairman.